Good afternoon, students. Department of Occupational Therapy and General Practice, Pronevich A.V. In today's our lecture, coronary artery disease, outpatient aspects of the diagnosis of various forms, and emergency care for inguinal attack and acute coronary syndrome on an outpatient basis. Coronary artery disease. This is an acute and chronic heart disease caused by a decrease of cessation of blood delivery to the myocardium due to an atherosclerotic process in the coronary arteries. The interaction of the above factors leads to the gradual development of atherosclerosis and the coronary arteries, the formation of atherosclerotic plaques, fibrotic tissue, narrowing of the vascular lumen, which is accompanied by an imbalance between the myocardium oxygen demand and its actual supply. The classification of coronary heart disease, it's categorized coronary artery disease or ischemic heart disease, and include 9 points. First, it's a sudden cardiac death, primary cardiac arrest. Second, the angina that divide into 3 parts: stable angina, unstable angina, and spontaneous angina. Stable angina includes 4 functional classes, as you remember, I hope. Unstable angina, it can be first-time angina, progressive angina, and early post-infection angina or post-operative. Spontaneous angina with a spastic variant of metal angina. Third, silent myocardial ischemia. Fourth, microvascular angina syndrome X. Fifth, myocardial infarction. It can be with Q-wave macrofocal transmural or non-Q-wave microfocal. Sixth, post-infection cardiosclerosis. Seventh, heart failure. Eighth, cardiac arrhythmias and conduction. And the last, ischemic syndrome, combination infection, standing myocardial ischemia, preconditioned myocardium. Angina pectoris. Angina pectoris is the symptoms caused by a persistent myocardial ischemia, which occurs wherever there is an imbalance between myocardial oxygen supply and demand. Atherosclerosis may by far the most common cause of angina pectoris. Angina may result from vasospasm of coronary arteries. This may coexist with atherosclerosis, especially in stable angina, but may occur as an isolated phenomenon in less than 1% of cases in patients with normal coronary arteries on angiography. This is sometimes known as variant angina, what is accompanied by chest ST elevation on the ECG, and is termed metal angina. Syndrome X. The constellation of typical angina offers objectively evidence of myocardial ischemia on stress testing and normal coronary arteries on angiography, and is sometimes known as Syndrome X. Traditional clinical classification of suspected angina symptoms. It can be typical angina, atypical angina, and non-anginal chest pain. Typical angina. It means the following 3 characteristics: constriction of discomfort in the front of the chest, on the neck, jaw, shoulder, or arm. Second, recirculated by physical exertion, and third, relieved by rest, only treated within 5 minutes. Atypical angina meets 2 of these characteristics, and non-anginal chest pain, it meets only 1 or none of these characteristics. This grading of both angina severity according to the Canadian Cardiovascular Society. First, angina with only stress and exertion. It's presence of angina during strenuous, rapid, and prolonged ordinary activity, walking or climbing stairs. Second, angina with moderate exertion, slight limitation of ordinary activities when they are performed rapidly after meals in cold, in wind, and emotional stress, or during the first few hours after waking up, but also walking uphill, climbing more than 1 flight of ordinary stress, or at normal pace, and in normal condition. Third, angina with mild exertion, having difficulty walking 1 or 2 blocks or climbing 1 flight on stairs at normal pace and conduction. And last, fourth, is angina at rest, no exertion need to trigger angina. It can be at rest. This is a score, a cardiovascular risk chart, 10-year risk of fatal cardiovascular disease. with high-risk regions of Europe. Belarus, it's a high-risk region of Europe, and it's it's risk less than 1, it's low risk. From 1 to 5, it's moderate risk. Higher is from 5 to 10%, and very high, more or equal, more than 10%. And as you see, as you remember, we should divide our patient, woman and man, smoker and not smoker, and according to age, it starts from 40 years old, and patient with as I said, total cholesterol, and you can see systolic blood pressure. And then you can check which risk has your patient. Of course, smoker males with high systolic blood pressure and with very high total cholesterol have very high risk, cardiovascular risk, fatal risk. These 10-year cardiovascular risk categories. It's low, moderate, high, and very high. Score risk, it's used for patient has no any cardiovascular diseases. These 10-year cardiovascular risk categories we used for patient with this disease. And you see that low risk has a patient with calculate 10-year score risk less than 1%. Moderate risk, it's for patient who has, according to score table, with risk from 1 to 5, or a patient has grade 2nd hypertension, or these mild age people belong to this category. High risk is a patient of the following that marked elevation of a single risk factors. It can be cholesterol more than 8, or it can be second, it was a moderate. For high risk, it's a third degree of hypertension. It's BP more than 180, 110. And most other people with diabetes, except some young people with type 1 diabetes mellitus and with one merger of risk factors, who may be at a moderate risk and very high risk. If the patient has documented cardiovascular disease as clinical, unequivocal, or major. This clinical cardiovascular disease and include acute myocardial infarction, acute coronary syndrome, coronary or other artery vascularization, stroke, transient ischemic attack, aortic aneurysm, and it can be peripheral artery disease. Or it can be significant plaques on angiography, ultrasound, diabetes mellitus with target organs, proteinuria, or with major risk factors such as grade 3 organ or hypercholesterolemia, severe chronic kidney disease, coronary filtration less than 30, or a calculated 10-year risk more than 10. Investigations. Basic first line. Test in the patient with suspected cardiovascular disease includes standard laboratory biochemical test. Resting ECG, post-ambulatory ECG monitoring, resting cardiography, and select a patient at chest X-ray. Such testing may be done on the outpatient basis. Hemoglobin is a part of the full blood count, and where the clinical suspicion is a thyroid disorder. A thyroid hormone level provides inflammation related is a possible cause of ischemia. Fasting plasma glucose and glycated hemoglobin should be met in every patient with suspected cardiovascular disease. A lipid profile includes total cholesterol, high density lipoprotein cholesterol, low density lipoprotein cholesterol, and triglyceride should also be evaluated in any patient with suspected CID to establish their patient risk profile and exertion to needs for treatment. The first line investigation in an exercise ECG, which should be performed using a standard treadmill or bicycle and a metro protocol, which monitors the patient pulse, BP, and general condition. Planar or down slow and CD segment depression of 1 mm or more is indicated of ischemia. The first A picture, you can see planar ST depression is usually indicated of myocardial ischemia. And second is to indicate myocardial ischemia. It's long, slow depression. But C, it's a normal finding, up, slow depression. Echocardiography is an important clinical tool for the exclusion of alternative causes of chest pain and as aid of diagnosis concurrent cardiac disease such as valvular heart disease, heart failure, and most cardiomyopathies. But it is important to remember that the disease often coexists with obstructive CID. To use an cardiographic contrast agent can be used in patients with poor acoustic window. Cardiac magnetic resonance may be considered in a patient with suspected CID when the echocardiogram having contrast is inconclusive. Chest X-ray is frequently used in an assessment of patients with chest pain. Functional invasive tests for the diagnosis of obstructive CID are designed to detect myocardial ischemia through ACG changes, one monitor abnormalities by stress, CMR or stress echocardiography, or perfusion changes by single proton emission CT. Positron emission tomography, myocardial contrast echocardiography, or contrast CMR. Invasive testing. Invasive coronary angiography is only necessary in patients with suspected CID in causes of conclusion non-invasive tests, or it can be in patients from participant profession due to regulation. Lifestyle recommendation for patients with chronic coronary syndromes. Smoking cessation, of course. Use pharmacological and behavioral strategies to help patients quit smoking. Avoid passive smoking too. Healthy diet. Diet with vegetables, high fruits, and whole grains. Limit saturated fats to less than 10% of total intake. Limit alcohol. Physical activity 30-60 minutes. Moderate physical activity most days, but even irregular activity is deficient. Healthy weight. Obtain and maintain a healthy weight or regular weight through recommendation, emergency intake, and increased physical activity. And other. Take medications as prescribed. Sexual activity is low risk for stable patient, non-symptomatic as low to moderate activity levels. Pharmacological management include antihistaminic drugs. Initial drugs therapy usually consists of one or two anti-anginal drugs such as necessary plus drugs for secondary professional cardiovascular disease. Beta-energy blockers or calcium channel blockers are recommended as a first choice. Nitrates. Short-acting nitrates for acute angina, sublingual or spray, nitroglycerin. Formulation provides immediate relief of throat angina. Spray nitroglycerin acts more rapidly than sublingual nitroglycerin. Long-acting nitrates for angina prophylaxis. Nitroglycerin is nitrate, mononitrate, should be considered as second-line therapy for angina, relief when initial therapy with a beta blocker known to hydropyridine, calcium channel blockers, is contraindicated. Beta blockers. The dose of beta blockers should be used to the limit of heart rate to 55 to 60 beats per minute at rest. The principal side effects of beta blockers are fatigue, depression, bradycardia, heart block, bronchospasm, peripheral vasoconstriction, postural hypotension, impotence, and making of hypoglycemia symptoms. Calcium channel blockers, hydropyridine such as long-action nifedipine or amlodipine. Ivabradine. Ivabradine has been reported to be a non-inferior to atenolol. Amlodipine is a treatment of angina and ischemia in patients with coronary disease. Nicorandil. Nicorandil is a nitrate derivative of nicotinamide with anginal effect, similar to those of nitrates or beta blockers. Ranolazine is a selective inhibitor of the late-inward sodium current. Trimetazidine appears to have a hemodynamically neutral side effect profile. Trimetazidine added to a beta blocker improved effort reduction in myocardial ischemia. It remains contraindicated in Parkinson's disease and motor disorders such as tremor, shaking, muscle, rigidity, walking disorder, and rest relax syndrome. Here you can see the steps according to situation. There's 4 steps. The first is standard therapy. Start with beta blockers or cancer channel blockers. Second step, add to beta blockers together with cancer channel blockers, and you can see dihydropyridine cancer channel blockers. Third, add second line drug. And the last 4th step, add nicorandin, ranolazine, or trimetazidine. If a patient has high rate more than 80, you should start from beta blockers or non-hydropyridine cancer channel blockers, and then you should add to beta blockers a combination with non-hydropyridine cancer channel blockers, and then add ivabradine. If your patient has low heart rate, you should start from dihydropyridine cancer channel blockers. If your patient has low ventricular dysfunction or heart failure, you should start always from beta blockers. And if your patient has low blood pressure, low dose of the drugs, or beta blockers, or dihydropyridine, non-hydropyridine cancer channel blockers. Event prevention. Antiplatelet drugs. Platelet activation and aggregation in the trial for symptomatic coronary thrombosis, forming the basis for the use of antiplatelet drugs in a patient with coronary disease, is view of favorable balance between the prevention of ischemic events and increased risk of bleeding. Low dose of aspirin 75 mg per day. Oral P2I12 inhibitors such as clopidogrel and prasugrel. Anticoagulant drugs in sinus read. Anticoagulant drugs inhibit the action or formation of thrombin, which plays a pivotal role in the both coagulation and platelet activation. Low dose of rivaroxaban. Rivaroxaban is a factor 10A inhibitor that has been studied at a low dose 2.5 mg twice a day in several population of patients in sinus read. This dose being 1/4 in the standard dose used for anticoagulant in patients with atrial fibrillation. Proton inhibitors. Proton inhibitors reduce the risk of gastrointestinal bleeding in patients treated with antiplatelet drugs and may be useful adequate treatment for bromatocephaly. Proton inhibitors such as clopidogrel, particularly improzole and omeprazole, may reduce the pharmacological response to clopidogrel. Statins and other liquid-lowering drugs. Patients with established CID are regular, has been at very high risk of cardiovascular events, and statin treatment must be considered. Level of low-density cholesterol levels. The goal treatment of low-density cholesterol level less than 1.8, or its leads to reduce in by 50% of baseline low-density cholesterol. It's from 1.8 to 3.5. Renin and aldosterone system blockers. Causes ACE inhibitors can reduce mortality, myocardial infarction, stroke, and heart failure. Among patients with left ventricular dysfunction, previous vascular disease, and high-risk diabetes, aldosterone blockers, spironolactone or eplerenone, is recommended for use in post-myocardial infarction patients who already received therapeutic dose of ACE inhibitors or beta blockers, have a left ventricular ejection fraction less than 35, and have ACE diabetes or heart failure. Revascularization. This recommendation suggests that revascularization in patients with angina and significant stenosis have often a second-line therapy after medical treatment has been unsuccessful. Acute coronary syndrome. A group of clinical signs of symptoms suggested in unstable angina or acute myocardial infarction with or without ST elevation. Unstable angina is resisted by a new onset of rapidly worsening angina of minimal exertion, or angina at rest in the absence of myocardial damage. Myocardial infarction differs from unstable angina, since there is an evidence of myocardial necrosis. The leading symptoms initiated the diagnosis and therapeutic cascade in patients with suspected acute coronary syndrome is acute chest discomfort described as pain, pressure, tightness, or burning. Chest pain with great symptoms may include dyspnea, gastric pain, and pain in the left arm. Acute coronary syndrome based on electrocardiogram (ECG). Two groups of patients should be patient with acute chest pain or persistent more than 20 minutes ST segment elevation. This condition is termed ST elevation, acute coronary syndrome, with general effects on acute total or subtotal coronary occlusion. Most patients with anti-ML develop ST elevation myocardial infarction. The method of treatment of this patient is immediately reperfusion by primary subcutaneous coronary intervention, or is not available in timely manner by a fibrinolytic therapy. Patient with acute chest discomfort but no persistent ST segment elevation, not ST elevation, located acute coronary syndrome, inhibits AST changes that may include transient ST segment elevation, persist on ST segment depression, T wave inversion, play T waves or pseudonormal of T wave. On the other, ECG may be normal. Acute coronary syndrome, universal definition of myocardial infarction. Acute myocardial infarction defines cardiomyopathy necrosis in a clinical setting associated with acute myocardial ischemia. A combination of criteria is required to make diagnosis of acute myocardial infarction, namely detection of the increase or decrease in cardiac biomarkers, preferably higher sensitive cardiac troponin T or I, with at least one value above the 99th percentile of the upper reference limit, at least one of the following. Symptoms of the myocardial ischemia. New ischemic ECG changes. Development of pathological Q waves on ECG. Imaging evidence of loss of available myocardium or new regional wall motion abnormality in the pattern consistent with the ischemic etiology. Intracoronary thrombosis, defect on angiography or autopsy. These cardiac biomarkers. We see that the troponin TOI are the first to rise, followed by aspartate amine transferase and then lactate ketopinase. In patient treated with perfusion therapy, a rapid rise of plasma creatinine kinase due to various effects. These two types of acute coronary syndrome with non-ST elevation and acute transmural myocardial infarction with ST elevation. The first non-ST elevation is the myocardial infarction. We can see the T wave inversion together with the reduction of higher of the error waves and leads to 1, second, third, and fourth. Second, myocardial infarction, acute transmural anterior myocardial infarction. So we can see elevation of the ST segment in a first, second, lead third, fourth, fifth, and sixth. As it's present of Q waves and leads V3, V4, and V5. Pharmacological treatment. Collection of complaints, anamnesis, examination, assessment of chest pain, its table, monitoring of hemodynamic parameters, its blood pressure, heart rate. Then registration of ECG in 12 leads. Call an ambulance with indication of the reason, it's acute coronary syndrome. Restriction of motor activity. And relieve the pain syndrome. First is glycerol nitrate. We can use and sublingual. The tongue spray can be dosed. It's not effect you can repeat twice after 5-7 minutes under the control of blood pressure and heart rate. In case of a pain syndrome that does not stop with nitrates, you should provide treatment of narcotic agents such as morphine, hydrochloride, and its solution together with sodium chloride. It should be intravenously slowly during 5 minutes and 3-5 milliliters until the pain syndrome is completely eliminated. Then salicylic acid 250-500 mg. If the patient used there is no sodium form, the drug is included. Patients who take non-steroid anti-inflammatory drugs for a long time, it's aspirin, both not selective and COD2 selection, should be stopped taking them at the time of detection of acute coronary syndrome. Clopidogrel, together with salicylic acid, includes 300 mg if a patient's age less than 75 and or 75 mg is a patient more than 75 years. Anticoagulant therapy, fondaparinux subcutaneously or enoxaparin subcutaneously or heparin intravenously. Beta blockers. Take in account contraindication. Metoprolol intravenously, it can be metoprolol succinate. Metoprolol tartrate, bisoprolol, carvedilol, nebivolol, it can be in tablets. ACE inhibitors, captopril, enalapril, ramipril in tablets. Statins, lovastatin, 48 dose once, can be rosuvastatin. If it indicates, provide intravenous drip injection of nitroglycerin or sodium nitrate. It should be drip injections, of course, in taking into account the presence of contraindication. It is necessary to ensure that during the admission of the drug, the heart rate does not increase more than 100 per minute. The systolic blood pressure does not fall below 100. Indication for reperfusion therapy. Ischemic chest pain lasting at least 30 minutes, not relieved by repeated intake of nitroglycerin, is accompanied by elevation of ST segments by 1 mm or more at least 2 advanced chest leads, or in 2 at 3 second sound and A with F, or the appearance of blockage of the left bundle branch block or endoventricular rhythm, and possibility of reperfusion no later than 12 hours from the onset of the disease. If symptoms last more than 12 hours with persistent or recurrent chest pain and present ST elevation, you diagnose left bundle branch block. Thrombosis or PCI for ST segment elevation with acute coronary syndrome. Direct angiography stent is preferred if can be performed by an experienced team of operation within 90 minutes from the moment of the initial medical contact of the patient to the placement of the balloon into the infect-associated artery. Thank you for your attention. See you in our practical classes.